Hello, and thank you for tuning in to my presentation, Occupational Medicine for the Primary Care Physician. My name is Davina Dyer, and I'm currently the Medical Director at Caduceus Occupational Medicine in Douglasville, Georgia. Just to give you a little bit of background, I went to medical school at the Morehouse School of Medicine and completed my medical degree there in 2004, and continued on at the Morehouse School of Medicine in the Department of Family Medicine, where I completed my residency in 2007. I practiced in primary care for about 1 year, and then started practicing in occupational medicine. I've been in occupational medicine now for almost 4 years, and I enjoy it. It is a little bit different from primary care, so I just wanted to give the primary care physicians here a little bit of background about occupational medicine, and also some of the most common presentations that a primary care physician would see as it relates to occupational medicine. Just to give you a little bit of background, occupational medicine is a branch of clinical medicine most active in the field of occupational health. Basically, its role is the provision of health advice to organizations and individuals to ensure the highest standards of health and safety at work. Occupational medicine also aims for the promotion and maintenance of the highest degree of mental, physical, and social well-being of workers in all occupations. Basically, an overview of occupational medicine, some of the most common things that you'll see in the primary care setting are work-related injuries. You may see someone coming in for alcohol and drug testing. Physicals, that's including physicals for the Department of Transportation, pre-employment, fit for duty, and annual physicals as ordered by their specific jobs or career type. Immunizations, including most of the most common vaccines, and also physical therapy for conditioning or work hardening. And I will specify and go into some details in each one of these categories and some of the most common presentations that you will likely see in your office. So work-related injuries sometimes present to the primary care physician. You may be that patient's primary care physician, and they may know of you as their doctor. So if they're injured at work, they may just come to you as their doctor. And work-related injuries is most commonly referred to as workers' compensation. It is important to know that workers' compensation laws vary by state. Currently, I practice in the state of Georgia, and I know the rules for the state of Georgia. So if you are participating in workers' compensation for companies, it's important that you understand the laws for that state. And usually work-related injuries and workers' compensation is usually regulated by the Occupational Safety and Health Administration, which is usually referred to as OSHA. Basically, OSHA was created in 1970 as a part of the Department of Labor. And basically, there are 3 different divisions of OSHA. One is for workers' rights, one is for employers' rights and responsibilities, and one is for the construction industry. And basically, OSHA's mission is to prevent work-related injuries, illness, and occupational fatality by issuing and enforcing standards for the workplace safety and health. Also is to establish and create a better workplace for all workers and to ensure the safety of everyone by making and enforcing certain standards that are needed to protect people. If we think back to the industrialized America, and we think about the factories and industrial plants that were where most of the workers were working, and after the Depression in the 1940s, 50s, and 60s. Some of those, before OSHA was created, some of those type of factories were very unsafe, whether it be from fumes, dust, asbestos, um, just the working conditions just weren't up to par. Some of those places started to create unions to speak on the behalf of the workers if something came up basically against the employer. But OSHA was created to make sure that a work environment is safe and that the people working in that environment are protected. So just OSHA being in place was very important for most of these type of industries. Basically, every work-related injury does not have to be reported to OSHA. It's only specific cases. And then you get what's called an OSHA recordable. Companies try to keep the number of OSHA recordables to a minimum. So just thinking about an OSHA recordable as comparable to a moving violation or a citation, a driving citation. If a company continues to get OSHA recordables, then their workers' comp insurance premiums tend to rise and tends to go up and get more expensive. Just as if you are driving and you get numerous citations, the next time you try to renew your insurance policy, the premium will likely go up. So in an effort to keep costs down, a lot of companies try to keep the number of recordables to a minimum, and we'll go over what constitutes an OSHA recordable and letting you all know in primary care some of the most common things that we do will likely result in an OSHA recordable. So what constitutes an OSHA recordable? Death. Death on a job site automatically is an OSHA recordable, no matter how it happened, or sometimes an investigation has to take place, but until it's found differently, if a person is at work and they happen to have a heart attack at work, until it's ruled that it's not something that was caused by the workplace, it would be considered an OSHA recordable. Days away from work, if a person is what's called lost time, if they go to the doctor and they injure their back and you just say, well, rest your back for 2 days, just be off from work for 2 days. Well, anytime you give days away from work, that would give that company a reason to have an OSHA recordable. Restricted work or transfer to another job. If you give a restriction to say that this person cannot perform this job and they have to do something different based upon the job description that was provided, then that would give them an OSHA recordable even at the most minor injury or exposure. Medical treatment beyond first aid. So anytime there's a laceration and a need for suturing, which is meaning that a small laceration can't be closed with the steri strip, even if one suture is placed, then that will constitute an OSHA recordable. If a prescription medication is given, whether it be the most mild Motrin 800 milligrams, that would give this company an OSHA recordable. Any type of fracture that results, any type of fracture would give an OSHA recordable, and any type of casting or rigid splinting would, as a treatment, would give the company an OSHA recordable. If there is loss of consciousness, say there is a head injury or someone is hit by a moving object, they're hit in the head. The only thing they might have on their head, they may not even have a laceration, they may have a minor bruise that just needs cold compresses. However, if they had loss of consciousness, that is an OSHA recordable. So these are the this is just some information that you would have to get in the history as far as loss of consciousness, because when they come to you, they may say that they feel fine, but if you document this in your history and in your visit note, when it is reviewed, it will be listed as a recordable. So just some of the most common work-related injuries. In 2010, these statistics were taken from the website of the Department of Labor. Um, just just to let you know, um, any of these injuries can relate and can result in death. And just to give you a statistic, that there were 4,500 workers died on the job in 2010. And most were due to traffic and vehicular accidents. But any of these, some of these common work-related injuries can result in death and incidents and accidents. So OSHA is important, and still is important in 2010 and 2011 in trying to prevent these injuries. Just to go over some of the most common work-related injuries, overexertion is very common, and it usually is resulting in muscle strains and sprains. The most common presentation that I see in my office is back, shoulders, and wrists. Most commonly the lower back after repetitive and continued bending, stooping, and lifting. Most common presentation is a lower back pain. Falls, whether it be from a high level, ground level, or just from slips, trips, and stumbles. Injuries are usually dependent on the specific mechanism, and usually resulting in different types of injuries, but is usually documented because most times it is what we consider a preventable injury. And just to note, as an OSHA recordable, that falls from a height of more than 6 feet, no matter what the injury is, no matter what injury results, falls from a height of 6 feet is an OSHA recordable and has to be reported. Highway accidents and motor vehicle collisions, usually resulting from DOT workers or drivers of commercial vehicles, are very common. Crush injuries, usually these are in manufacturing and factory settings, using heavy machinery, and also repetitive motion injuries. Carpal tunnel syndrome is the most common one that I see in my office, and blunt trauma, whether it be from swinging material or being run into by a forklift. I see it all. Workplace violence. You may not think this is considered to be a work-related injury, but I've seen work-related violence, whether it be two employees who have a physical altercation. I have to treat the injuries for that. That would be considered under workers' comp. Or I've seen as much as a salesperson being robbed and stabbed, and after they were released from the hospital, status post pneumothorax, hemothorax with the chest tube. I see them as a follow-up, just to see, make sure to document everything and to make sure that they are ready to return to work. So some of these things that we might not think of as work-related injuries are very, very common presentations and may even present in your office. So just note that this should be listed under workers' compensation, not necessarily just primary care. So the most common presentations are going to be lower back pain, shoulder pain, neck pain, knee pain, wrist pain, ankle pain, finger pain, lacerations, and foreign bodies or substances to the eyes. When you see pain or lacerations or any type of foreign substance about it, foreign body or substances to the eyes, the most important thing is documentation. Documenting everything. So documenting how it happened. and just evaluating and treating a work-related injury. Um, Obtaining an authorization for the evaluation and treatment, if possible. In the state of Georgia, for the initial evaluation of a workers' compensation injury, it is to be paid for, whether you have an authorization or first report of injury or not. You want to obtain authorization if possible because you want to know exactly what the employer is looking for. You want to be able to get a job description if you can, and it is good to be able to communicate with the actual employer. So authorization and follow-up treatment is important because having an authorization basically determines who's going to pay you for seeing this patient. As you may know, that if you bill for work-related injury under a primary care insurance, that claim is likely going to be rejected. So having an authorization to know who you're going to bill for your billing department is very important. A thorough history. If we think about all of our medical documents are legal documents. However, most of the time through the history, the patient is not likely trying to come against you, but we have to think about this being a legal document, as some individuals who are injured at work tend to want to sue their company. And by us having a thorough history of exactly what the individual stated to us is very important for us as documentation and for the company as well. So having a thorough history is very important, as is in any medicine. A thorough physical and documenting all of the objective findings and pertinent negatives as it relates to the specific injury. X-ray, if necessary. In my practice, it's standard for us to X-ray every injury, just so we can document a positive or negative finding. And having a treatment plan and explaining that to the patient is very important. Explaining the medications and when they should take them. Explaining rest, ice, compression, and elevation. Referral to physical therapy or a specialist. You want to explain a treatment plan to the patient because if they work in a factory where they have to be alert, you want to explain to them that they cannot take muscle relaxants while they're on the job. You have to explain to them what the side effect of the medications are and what are some things that they have to look out for. The same way we would explain it to our patients, but it is even more important now because if they are returning to work or returning to a factory, or if they're a driver, you want them to understand that the medication or whatever you're giving them is safe for them to use, whether it be at home or at work. So sometimes I dispense my own medications, and sometimes I even write on the bottle, do not take at work or only take at night. Because we can list it, take this medication at bedtime, but sometimes the patients, they might be at work and they may just start having some pain and they may have the medications with them and actually take the medication. So just in a legal standpoint, you want to document when they can and cannot take specific medications. In evaluating and treating a work-related injury, you always want to address the patient's work status. Off work just means that the patient cannot return to work for whatever reason, whatever type of injury they have. In that sense, I recommend that you call the employer to discuss why the patient is off from work, because as you know, an off work status gives lost duty, which is an OSHA recordable. So for minor injuries, if you can have the patient go back and do something modified, then sometimes the company can appreciate that more, as opposed to just saying, hey, you hurt your back, you can't go to work. A modified work, you can specify what the restrictions are, whether it be the number of pounds, maximum that they can lift, push, or pull, or even the number of hours that they can work. If their job normally has 12-hour shifts, and you say, well, this person can probably work about 4 hours based upon what they do in their injury, then you have to list that in your paperwork and document that. Also, the number of hours of standing, sitting, and walking. You want to limit or no bending and stooping. The more specific that you can be in your modified work restrictions, the better it is for the patient and the employer. And also, there's a full duty status. Some injuries may be minor and the person can just return back to work to full duty. And you just want to document that, because once you return them to full duty, they are expected to perform all of their work, and their production is expected to be up to what the level of a non-injured person would be. So if you return someone to full duty, they have to understand that they have to perform all of their job functions based upon the job description. So that's one reason why you want to request a written job description if there's any question of what the person is doing, because you want to know exactly what they are required to do for their job. You also want to discuss the restrictions with the employer, as I said, especially if there's going to be an off work status or specific restrictions. Some employers may not necessarily have a restricted duty. If you say that the person can't lift over 10 pounds, everything in their factory may be over 10 pounds. So they may just tell their employee, which will be your patient, not to return to work until they're released to return to full duty. You want to make the employer aware of the next scheduled follow-up appointment. In the state of Georgia, whenever a person has to follow up for an appointment, they are to be paid for that appointment if they're on the clock, and they are supposed to be allowed to go to all follow-up treatments and appointments. So if an appointment is at 9 a.m. and the person starts work at 7 a.m., the employer is obligated to allow them to leave work while still on the clock, go, come see the doctor or go to whatever treatment or physical therapy that they're going to, and return back to work without any type of penalization or decrease in in pay. So addressing the follow-up, close follow-up with these patients, usually no more than 4 to 5 days for just a regular injury. Of course, if you're doing wound care or something like that, you may want them to follow up sooner. If they're in an off work status, of course, you would want them to follow up sooner. If certain type of injuries, you may have them follow up every 2 days. But you want them to follow up no more than 4 days, especially if they're on an off work status or modified duty. You want to be evaluating them to see when they can return to work and to make sure that your treatment plan is appropriate for them. You want to explain to the patient what to do if symptoms tend to worsen. You do not want them to go to the emergency room or the emergency department for a non-emergency. Some people tend not to know exactly what to do, being that it's workers' comp. If you are a workers' comp provider like I am, and they know that it's only for work-related injuries, and you explain to them that in Georgia, once you start coming to a provider and you come more than twice, then that constitutes your workers' comp provider, and you aren't to be seen by anyone else without the permission of your company. So with that being said, and they get all of the rules from the Department of Labor, if something happens, they tend to just go to the emergency room. You do not want this to happen. You want them to know that they can call your office, and that even if it's just for pain, they can call your office, and if they need to come in the next morning just to be seen and get a different pain medication or have medications modified, that would be appropriate, even if it's not time for their follow-up appointments. So just moving forward with drug and alcohol testing, and this is something that most workers' comp providers usually ask for a drug and alcohol test if a person is injured on the job. But all of them are usually done at the request of the employer. Regulations differ based upon the employer's governing entity. So some drug and alcohol testing may just be company policy, which means it's a non-regulated test, which just means that company decided that they're going to be a drug-free and alcohol-free workplace. With that being said, a drug-free workplace may not necessarily be regulated by the government, and we do their drug screens basically as a non-regulated drug screen and non-regulated alcohol screening. So federal employees may have a policy based upon what their job is as it relates to the federal government, and that is what's considered a regulated test. And your staff must be certified to perform any type of regulated drug and alcohol testing. So there are several reasons why the company may order drug or alcohol testing. It could be for post-offer, which means that they've offered the employee a job, or they offered the person a job, and they say, well, now that you've been offered a job, you must pass our drug test and you must pass our alcohol test. Post-accident, like I described with work-related injuries, or sometimes a post-accident meaning, you know, a truck driver hit a fence or hit another car. No one may have been injured. However, that post-accident or post-incident drug and alcohol testing may be required by that company. It could be for a random drug and alcohol test. Usually regulated companies have a rule that every quarter at least 25% of their employees have to be randomly tested for drugs and alcohol. That's usually a law under the Department of Transportation, and those are regulated tests. And the random pool has to be totally random. It can't just be someone just deciding who they want to test. It has to legally be from a random pool. For cause of reasonable suspicion, someone may be on the job site who smells of alcohol, or someone may be on the job site who seems to appear under the influence of drugs or alcohol. They may be sent to your office for testing. A follow-up drug and alcohol test usually is when a person is found to have a prior positive drug or alcohol test within their company. Their company is usually required to have some type of follow-up for them as far as drug and alcohol counseling, and they will do periodic what's called follow-up tests, where they will come in every month or every 2 months or even every 3 months just to be tested for drugs and alcohol. Also, as far as returning to duty, a person may just be out of work. Maybe they went to their primary care physician and they ended up having to have a major surgery, or they just were on Family Medical Leave Act for 12 weeks and they return to their duty. Their job may require a drug and alcohol test before they return to their normal duty. So basically, some of the most common samples that are used in drug testing are urine drug screens, and that's the most common one that I use in my office, which is usually the least expensive and the one that most companies are willing to go ahead and pay for. Blood drug testing is not done very much. Saliva is becoming more popular, and hair sampling is popular among some of the federally regulated companies. The thing with hair sampling is that sometimes you may be doing a post-offer drug screen and you just want to see if a patient or a person is has been using drugs. It may not have been in the last 2 to 3 weeks. It may have been 4 to 6 weeks, and the hair sample may still be positive. So sometimes having a positive hair sample does not necessarily mean that the person is actively using drugs. So there is some controversy now about using hair samples for pre-employment drug screens. So most of the time, for the legal issues and questions, most companies, like I said, are using urine, and which is an inexpensive way for testing as well. For alcohol testing, the most common samples are breath alcohol testing. In my office, we have a breath alcohol testing machine, which is actually set up, and we purchased it from a company who sets up breath alcohol screenings for the Department of Transportation and federally regulated tests. And it works very well in the calibration, and it will stand up in court legally, basically based upon the printouts. The date and time and everything will be printed on the printout, and it'll actually print out what the level is. And it's different in different states based upon what's considered intoxication and that type of thing. But if a company has an alcohol-free workplace, any number other than 0 would be considered a positive. So saliva testing for alcohol is not as common, and blood testing it's a little bit more expensive, but those are samples that some companies tend to use. But just by you doing the exam, you're not necessarily determining the consequences. The consequences of positive results are usually based upon the company. So for non-regulated, just company policy, they may say that this person is terminated, and we'll just have follow-up for them, or we'll recommend follow-up for drug and alcohol programs. For regulated exams or regulated drug and alcohol screenings by the federal government, usually they have to be removed from the safety sensitive or the position that they're doing for at least for alcohol screening, it would be for at least 6 hours. And usually they have to be retested again before they can return. Now, as far as other consequences, just for them having a positive result, that would be whatever their company policy is, whether it be just counseling and follow-up exams, or whether it may be being terminated from that job. Usually just in my practice, just doing the test. I never know. Sometimes the patients will say, my test was positive, and what do I do? The most important thing to do is just let them know you're doing the test, and you're just giving the results. You are unaware of what their company policy is, and just leave it at that. So moving forward to occupational physicals. Some of the most common physicals that we do are ones for the Department of Transportation. Basically, it's just done to ensure that the person is healthy enough and fit to operate commercial vehicles. And we see pre-employment, post-offer, fit for duty, annual, sometimes hazmat physicals. Usually that's done to ensure that major chronic disease, if present, is controlled, and that the person would be healthy enough to perform whatever the job description is. Basically, all the physicals are pretty much normal physicals that you would normally do in your office, but I'm going to focus on the Department of Transportation physical because that is a specific form, and there are specific requirements that have to be met through the Federal Department of Transportation for you to actually clear a person to drive a commercial vehicle. And some of these are the most common presentations you'll see in your office as it relates to the DOT physical. So basically, the standards are set by the Federal Department of Transportation, and the physical must be done on a specified form. The format may be different for a lot of the different forms, but all of the questions are mandated by the Federal Department of Transportation. The driver must also be issued a medical clearance card. So just a side note, if you do not have these items in your office, you cannot legally perform this physical. Um, so just to be able to say that you cleared somebody for the Department of Transportation just by doing it on a regular physical form is not going to be legally feasible. I have uploaded just some of the document of the physical form, and I'm going to go over each section. This is very important. If you get these forms in your office and you're doing the DOT physicals, these are some things that you would just look out for and be able to evaluate and discuss with your patients. So basically just section 1, the driver completes section 1. You want to make sure that everything is printed and filled out appropriately, including the reason why they're here, whether it be a new certification, recertification, or follow-up. And as I go through that, you'll understand why we need to know if it's new or recertification. In the health history, the driver also completes this section, and you ask them to answer every question individually, which means check off no or yes. For the Department of Transportation, a line drawn through no will not be feasible. Each question has to be answered separately. So if they answer yes to any of the questions, they are to list why they put yes and list all the medications, including over-the-counter medications that are used regularly or recently. And you're going to make sure that they sign and date that. When you review this, you want to comment on the health history, so you want to even ask to them to specify things. Even if they've already listed it out, you want to just ask them again so that you can have a clear understanding, and you can document that on these lines where it says medical examiner's comments on the medical history. This is section 4. Actually, we skipped section 3. I'll go back to that. But the rest of it in section 4 is actually done by your medical assistant or your nurse or whoever's getting your vitals. They must be trained to do what's called a whisper test. And the driver must be able to perceive a forced whisper greater than 5 feet away with or without a hearing aid. And so if they cannot hear greater than 5 feet away, just a whisper test, and they do or do not have hearing aids, you cannot clear this person for to be a driver for the Department of Transportation. You can also do an audiogram, and in my office I do have an audiogram booth to do audiometries, and if you if their better ears are less than or equal to 40 decibels, then they can still pass their exam. But most primary care physicians don't have audio booths in their office to actually test this. So you would either have to disqualify the person and refer them out for impaired hearing. And moving on to section 5, which is the blood pressure and pulse rate. Having uncontrolled blood pressure is the most common reason in my practice that I cannot clear someone for their DOT physical. The blood pressure goal for the Department of Transportation is less than or equal to 140/90. And if a person comes in for a new certification, and their blood pressure is greater than that, their blood pressure can actually be up to 160/79 with a diastolic of 100/109, and you can give them a one-time certification for 3 months. However, if they are coming in for a recertification, they will be disqualified for a blood pressure being that high. A recertification, the highest that the blood pressure could be would be 140/159/91/99, and they will be able to get a one-time certification for 3 months if it's that high. But once they return, their blood pressure has to be less than 140/90 for them to be cleared, and the maximum clearance that a patient can get with a history of high blood pressure is 1 year. So with that being said, even if their blood pressure is 120/80 and it's controlled with all of their medication, the maximum clearance that they will be able to get is 1 year. Other testing, a urine dip test. You can do a UA in your office, just checking the specific gravity and protein, blood, and sugar. Usually in my practice, if they just have a 1+ protein or a 1+ blood with negative sugar, I'll just go ahead and clear them and let them know that those were the findings. If they have anything more than 1+ protein and 1+ blood, I usually refer them to their primary care physician for further testing. When it comes to sugar in the urine, if they have any amount of sugar in their urine, I disqualify them. Sugar in the urine for the Department of Transportation is a sign of uncontrolled diabetes. So even if a person has diabetes and they don't have sugar in their urine, just by them having the chronic disease as diabetes, the Department of Transportation doesn't necessarily want to check an AccuCheck, but sugar in the urine indicates that your blood sugar is high, and so they will disqualify. They want you to disqualify that person and refer them to their primary care physician and document that they are being seen and treated for their diabetes. And going back to section 3, which is the vision test. There is a standard set by the Department of Transportation that vision has to be at least 20/40 in each eye, with or without correction, and at least 70 degrees peripheral in a horizontal meridian in each eye. So if the person can see without glasses and they see at least 20/40, you just document that and document that corrective, they did not need corrective lenses. And they must be able to see the standard traffic control signals, which is red, green, and amber. So at your vision, Snellen vision chart, you also want to put the colors red, green, and yellow and ask them if they can see those colors. So you just say, what do you see? What colors do you see? And you just want to make sure that they can see those. Now, if a person can see and they are using their glasses, no matter what their uncorrected vision is, you want to make sure you test both. But whatever their corrected vision is with their glasses, you want to document that, and you want to document that they only meet the standards with corrective lenses, because that has to be documented on their form as well. Monocular vision, meaning that they can only see out of one eye, those drivers are not qualified. They are automatically disqualified if they can't see out of both eyes. So monocular vision, if you say yes, then you do not have to even move forward with the rest of the exam, that driver is disqualified. So just moving on to the physical exam, this is the part that you would complete in your body systems. These are some of the things the Department of Transportation wants you to look for. If everything is normal, you just check the no box. You can check the no box all the way down. If something is positive and you mark yes, you just want to comment on that and letting them know that this is why this is abnormal. And if it's something that needs further workup, then you want to document that as well. So you want to note the certification status at the end of the physical, whether it be meets the standard for 2 years, does not meet the standards, or meets standards but periodic monitoring is required. This will be in your hypertensives, your heart disease, and your diabetes, who only qualify for 1 year, or for your recertifications or your new patients who come in with uncontrolled hypertension. You can give them a 3-month card and have them follow up with their primary care physician. Or temporary disqualified due to a certain medication. There are certain medications that would automatically disqualify automatically disqualify a driver. Wearing corrective lenses or hearing aids, you want to document that, and you want to document if they had a waiver or a skill performance evaluation or any exemptions. You want to just document that, because whatever you document on their form has to be documented on their medical card, in which this is an example of a medical card that you would have to give the person. They would have to have this with them at all times, because if they are stopped while driving a commercial vehicle and they don't have the certification card or their physical form, a copy of their physical form with them, they can receive citations. So I've highlighted the areas where the driver is supposed to fill in all of their information, and then the other part is where you as the provider will fill in your information. And you want to make sure that you really document and bold the medical expiration date for this card. And the maximum that a person could be certified for is 1 year. I'm sorry, is 2 years and 1 year for chronic diseases. So just going over some of the DOT important facts. Like I said, the maximum certification is 2 years for healthy drivers, and the maximum is 1 year for chronic illness such as diabetes, hypertension, and heart disease. At your discretion, you may give a 1 month, 3 month, 6 month, or 9 month certification if medical conditions are not controlled. Like I said, i.e. the blood pressure is 150 to 159 over 90 to 100. Certifying criteria: the must have blood pressure less than or equal to 140 over 90. The driver must have vision in each eye of 20/40 or better. And they must be able to hear a whisper greater than 5 feet away or be cleared by less than or equal to 40 decibels in an audio machine. But in most primary care settings, the whisper test is going to be the most common test that you'll do. They must have a urine free of glucose to be certified. And some of the medications that automatically disqualify drivers are the use of insulin or anticonvulsants. And if you look back at the health history where it says diabetes, it was listed as diet controlled pills or insulin. If they mark off insulin and you review that at the beginning, you don't even have to move forward with the rest of the physical. You know that this person is going to automatically be disqualified. So just moving forward with some of the other smaller things that we do, immunizations. Most primary care physicians do immunizations anyway, but some of the immunizations are recommended or required by some employers. Some work-related injuries require tetanus boosters, whether it be lacerations or major abrasions. And since 2009, major employers have encouraged their employees to have flu vaccines since the widespread influenza swine flu in 2009. So depending on the industry, some employers require TB skin tests, Hep A and B series. Usually that's in healthcare workers, home health, nursing home, hospital, and sometimes even physical therapy settings. Where they recommend that their employees have these, and we usually have these in our offices. Primary care physicians usually have these vaccines in their offices anyway. The military and international companies usually require vaccines such as typhoid, yellow fever, pneumococcal, and anti-malaria. Most of the time we'll have the pneumococcal in our offices for primary care. But the typhoid and yellow fever, some occupational facilities have it, but most of the time the health department will do that, as well as the anti-malarials based upon whatever they're needed and what length of time they need it for. So if you do have anybody in the military, usually their military unit will tell them exactly what they need to do or even dispense the medications. And if they come to an occupational medicine setting, you would know exactly where to refer those people to, which would be your local health department. Physical therapy. We actually have physical therapy on site at our offices. And what we tend to do is certain injuries, it's been proven and study, and it's been proven that physical therapy usually helps patients return to work without the risk of re-injury sooner than not doing therapy. So that's evidence-based medicine. Occupational therapy, we perform that as well. Work hardening, meaning just conditioning and being able to do a certain job. Our physical therapists do working as far as ergonomics, as far as sitting, standing, uh, bending, stooping, pivoting. Our therapists in occupational medicine tend to work with the patients on that. That usually just reduces the risk of re-injury. Evaluations of functional capacity. Some companies, if a person has been injured and they don't know exactly what they can do as far as functioning, or what job description they'll be able to, what job they'll be able to do based upon the job descriptions in that company, they will have the physical therapist do what's called a functional capacity evaluation. And that is a very extensive evaluation based upon the entire body and functioning. And it's usually everything is typed in into a program, and it's usually generated electronically of the percentages of functionality for the person. And the main goal in occupational medicine for the physical therapist is to treat the patient and have them return to work and reduce the risk of re-injury. Usually if I'm seeing a patient who was injured, let's say in a motor vehicle collision, while working, they were driving their patrol car, they were rear-ended by another car. Being that we know after motor vehicle collisions and those type of strains or sprains, I may order and refer them to physical therapy on the initial visit to go ahead and get it started, so that the person could be doing exercises with the therapist, and usually the therapist recommends home exercises. Usually this is a therapy that they have to come into the office for. It's usually not approved for home health physical therapy. Usually workers' comp does not approve home health physical therapy unless the patient is has a very, very severe injury where they can't necessarily come to therapy, or maybe easier to do it at home. So in conclusion, basically occupational medicine, we basically want to evaluate and treat the patient accordingly. We have to understand that in occupational medicine versus primary care, that we have three people involved. We have the patient, we have the employer, and we have the insurance company, as opposed to primary care, where it's just the patient and the insurance company. It is important to understand that the rules of HIPAA do not apply to workers' comp. So if you see someone who was injured on the job in your primary care office, and the employer calls you and says, I need to know exactly what's going on with patient A, then the patient does not have to sign a release for medical information, or they do not have to send a request or pay for medical records, because HIPAA does not apply when it comes to workers' compensation. So you can communicate with the employer, and that is very important when you're taking care of a patient in your primary care setting, because they may or may not necessarily, you may or may not necessarily print out your visits as we do in occupational medicine, knowing that the patient has to take those documents back to their supervisor or their employer. Also, being familiar with the DOT standards, like we discussed the DOT physical. DOT physicals are very easy to perform. It's just like performing any other physicals, and if you want to start doing them in your office, just make sure you get the specified forms and specified medical clearance cards so that you can give that to the patient, and or give it to the company so that you're doing it on the federally approved form. Being familiar with the laws in your state. As I said earlier, workers' compensation laws differ from state to state. So being familiar with what's in your state, what the fee schedule is in your state for your charges is important. Also, being familiar with OSHA standards and what makes an incident or accident recordable. Is important to know, because some of your employers who you'll be working with may be in factory settings or construction settings, knowing that any recordable can make it, cause an increase in their workers' compensation insurance. You just want to see if you can work with them in keeping their recordables down if you're going to be seeing their employees for workers' compensation. That concludes the presentation. If you have any questions, my name is Davina Dyer, and my email address is listed at ddyer@caduceus24-7.com. You can send an email at any time. My office number is 678-483-0288. My office is open from 8 to 5. You can call during that time. Anytime you send an email, or an email may be the best way to send a question, but you are welcome to call me as well. There are CME questions that are after this presentation that you can complete. I do have an answer sheet, but if you have any questions regarding the CME questions, you can send me an email or give me a call. Thank you very much.